Right now, I'd just like to welcome Drake to give his presentation. Thanks so much.
Yeah, thanks, Leah, and thanks everyone for inviting me and having me kind of kick off the first ever ECHO series. I'm excited to listen on later on, but now I'll just kind of talk a little bit about my role and provide some key points that I think we can add to the assessments that you guys are already doing that are so great. So yeah, again, about my role, all I do is talk with patients about pain. I also talk with other healthcare providers and talk about pain. It's what I do day in and day out. Up until last week, it was just 3 days a week, and now I'm full time. So this is all I do is chronic pain work. My role and what we actually do with patients is we provide education. So this is usually in a group class over Zoom, but we also provide one-to-one health coaching as well, whether it's in person or on the phone. Our overarching goal is that we're providing this education. It's kind of opening up a lot of different doors for clients with their chronic pain management, and it's ultimately leading them towards self-management, as well as equipping them with some resources and tools, which can include multidisciplinary members, but also just different community services as well. Just kind of reading over the chat, we have a big range of people here. I saw some people working directly in burns, some people directly with chronic pain, and I'm sure we have a big range of knowledge for chronic pain and what we're seeing. The most common diagnoses I see are fibromyalgia, lower back pain, and osteoarthritis. So just to kind of think of what I'm usually seeing, those are my top 3, but I get everything through my door. Any pain 3 months or greater I work with, so that means I get flooded with a lot of referrals, which is great. So the reason I love this work, I've hopped around with nursing quite a bit, and I've really landed here, and I think I've found my home because I've always been interested in the whole person, and I think chronic pain, that's what we got to help people with. So when we help people with their pain, they got to return to the things they love. I've a lot of heartbreaking stories that I hear day in and day out, but when we work with people along this over a number of months or weeks, and we see them improve, the parts that sustain me with this work is that we get to, people will return to family bike rides or nature photography. They can manage their pain, or they're simply just spending more time with their family. So it's not just about reducing pain, this number on a scale that we try and get patients to to throw a number at, but it's helping them get back to living, and it's that quality of life piece. That's, I think, what makes me want to be involved in healthcare. It's not just the science of keeping people alive, but it's the art of helping people return to what makes life worth living. That's what makes us, humans and not robots. So I'll just go to the next slides. So what I hope you'll get out of today, that will recognize that education, it is a treatment in and of itself. We're empowering patients, and they're a team member as well, and we want to give them the insight and knowledge to choose directions and choose paths for their chronic pain. Secondly, we'll explore the complexities of chronic pain, and I'm hoping that we'll do that together here, but also bring this to an intimate conversation with your patients. And then lastly, we'll use language that moves forward. So how are we gonna, where are we gonna go forward with this education? What is it a stepping stone towards? And we wanna begin with some language. I also wanna keep in mind that pain education, it's a very delicate dance. There's many times I've said the wrong thing, and you gotta back up or make sure the client's understanding of the language that you're bringing. So it's a very delicate dance that takes a lot of time, and usually it's not this one-sided conversation. So I can't cover all of the nuances, but I'm hoping I can share some key elements that I've found. So education as a treatment, my overarching goal, my hidden agenda is I want clients to view chronic pain through the lens of the nervous system. So if it's back pain, it's not just about their back, it's about their whole picture, the whole person, the whole human that's there. When we get the client to understand this nervous system approach, that opens those doors within that biopsychosocial model. So if they're initially starting with biomedical, we can use education simply to show this whole picture. And then from there, that's when we can promote those treatments that are available. So with education, when I'm working with clients, usually we got to first just understand how pain works. I say, we almost want to look at pain from a distance right now, almost like an art piece. We want to be curious about it, understand what's going on. We're going to figure out how this applies to us in a moment, but for now, we're just going to be interested about pain. So the role of pain, how it's supposed to work, it's supposed to protect us, and it's supposed to tell us about danger. We're here in this Zoom session, and afterwards, maybe we're going to go enjoy the nice weather. We're going to go for a walk to the park. I'm hoping this doesn't happen for anybody, but let's say we're walking. If all of a sudden we stepped on a nail, we probably want to know that we did that. So pain is a really good way to let us know, hey, there's something dangerous going on, something we need to protect ourselves from. And so our nervous system sends pain as a messenger telling us about danger. So as I have written there, pain, it's not this external enemy that we have to fight or get rid of, but we want to recognize that pain, it's actually coming internally. It's this messenger telling us about danger. But there's a lot of other messengers we have in our body as well. So just like hunger, sleep, or thirst, these states aren't things that we want to be in. We don't want to just say, you're in pain, that's just a messenger, job's done. This state is telling us about something. So just like hunger, maybe it's telling me I need to refuel with nutrition, but also that messenger can be a little complex too, where even with hunger, maybe I'm dealing with some emotions or stress or tiredness, and my hunger cue is a bit more inflated due to those situations. So pain is a messenger, but it's complex. It's not as straightforward. Acute pain, when we know something's going on, like a broken arm, we can kind of find an isolated incident, we fix the arm, the pain should go away. Chronic pain is where it gets a little more complicated. So I'm doing this, in saying this, we're looking at the nervous system, we're looking at the brain, and the thing I really hear consistently, and unfortunately from patients, is that sometimes when we do this in a really quick conversation and we aren't checking the understanding of patients, they sometimes hear it as, well, pain's just in my head. Pain is something I gotta just stop thinking about, and I won't have pain. That's not the message we want to ever have patients hear. So really be cautious in your wording that it's not coming across this way. So I like to say the nervous system, because that kind of brings it like it's almost like it's an organ, because it is. We can't just tell our liver to metabolize differently. We can't tell our kidney to, output different amounts of urine. These are things that are automatically happening within our body. And our brain, it's not this light switch that we simply turn off and on and decide if we have pain. It's stuff that's doing, that pain is coming unconsciously and automatically. And this response of pain, or this messenger of pain, it involves many different aspects of our life. Next slide. So after we provide this education, we're having this conversation with clients, we've hopefully expanded them into looking at the nervous system and how it's pain is not just about the tissues, but it's about you as a whole person. And really, that's the biopsychosocial model. The biopsychosocial model is just a really smart way of saying the whole human. Who are you now? Who have you been? What environments are you? What are you thinking? And all of these things are really important with pain. This is both a good thing and a bad thing. The bad thing so far is that we've probably missed those pieces with our pain. If we've been so focused on our back, we've probably missed the stress and the worry and the beliefs about our back. But we now know the good news of this is that if we change some of those things, then we can look at reducing our pain. So with assessing a client's knowledge, we don't want to simply just say these things and just assume that they know it. There's a lot of times that we'll just read over a pamphlet. Did you hear what I said? Check, great, move on. But if we were to quiz that same client on the things that they just heard, what we're finding is that they're not passing those sorts of tests. So we want to, when we're doing this education, we want to assume that, we want to assess that they are learning what we're talking about. So one thing that I'll ask clients is, why do you have pain? I want to assess their understanding of what's going on in their body and why they have pain, as well as just what could be driving their pain in the first place. So as I mentioned, I work with a lot of clients with fibromyalgia. Many have had this for 15 or 20 years, and I'll hold my rant here, but this is something where when I ask this question, I say, well, what's driving your pain, or what is fibromyalgia, or what's going on in your body? You've had this for 20 years. Tell me what's going on. And often they have no idea what's going on in their body. They have this diagnosis. They say, well, I have pain because I have fibromyalgia. Well, what is fibromyalgia? And at this moment, I'll usually explain, with fibromyalgia, it's really about this nervous system being really, really sensitive. So someone without fibromyalgia, we brush that arm, and there's no injury, there's no scratch, and there's just a vague physical sensation there. But someone with fibromyalgia, we brush that same arm, there's no injury, there's no scratch, but it sounds like you're having real intense pain. And the client will usually agree. And from there we say, well, we know that there's no injury, there's no scratch, but this intense pain is very real for you. We want to figure out, why is this sensitivity going on? It's almost like this volume knob where, that physical sensation of a brush on the arm, that should be a 1 out of 10. But someone with fibromyalgia, it's a 10 out of 10, and it really hurts. For some clients, even putting on certain clothes, or the wind, or different pressures, or just what should be normal sensations are causing this extreme amount of pain. So explaining it as this idea of sensitization rather than someone with fibro being focused on these tissues, we kind of open up those doors and kind of bring some enlightenment on how to manage their pain. Previous to this, they'd have a pain flare up in their shoulder, and they'd go, I want to see my doctor, get an x-ray, look at what's going on in my shoulder. But then a week later, my pain is flaring up in my leg. Why is that going on? And if they're very focused on their tissues, they're going to be thrown in a lot of directions. But when we look at it from the nervous system, that's when this stuff sort of makes sense. This isn't just for fibro, but this idea of central sensitization, or that nervous system cranking up that pain dial over time, it happens for all the chronic pain that I'm seeing here. Whenever we have pain 3 months or longer, our nervous system starts to wrap its hands in there, and we unfortunately have neuroplasticity working against us, and that pain, those pain pathways in our brain start turning up, and we want to figure out, how do we turn those down? So to summarize, it's not just about the tissues. We want to expand it into the whole person, and looking through the lens of the nervous system is a great way to get to that point. But my next question that I'll talk with patients when we're getting their history is, I'll ask, when did your pain start, and what was going on around that time? Next slide. So emotional injuries matter. That biopsychosocial model, there's a lot of areas to explore, but the one that I find that at least I'm passionate about, and at least I'm seeing a high connection of, is that these emotional injuries really do matter in the physical manifestation of chronic pain. So what I have here on the diagram, we have on the left side of the line is beginning of life, and then on the right side, end of life. And when someone comes to me with chronic pain, typical onset between the ages of 30 and 50, and then another high end is around 65 for what I see. When I'm working with a patient, I'm not just looking at their pain now and how to move forward, but we want to recognize what experiences have happened in their life that have caused their nervous system to turn up that sensitivity and increase that pain response. So this can be things like that childhood abuse, trauma, various adverse childhood events, but even things like workplace environment, toxic work culture, or family relationships. All of these various emotional injuries really do matter. And what I'm finding is that there's a high frequency of trauma origins, as well as pain onset is really connected to a stressful time for a lot of clients. So we don't want to miss that piece in our assessment. And when we help clients connect this as well, sometimes we feel that pressure as a clinician. When we ask these questions, we have to be the one to fix it. There's resources we can give, but also just recognizing the patient is really important piece of this picture, and we can empower them with knowledge and resources, and again, open that new path for them to go through. So again, we have a varied audience here, and maybe fibromyalgia, this is something that you think makes sense, but what about, but I've had another client that you'd think would be kind of your typical organic chronic pain case. So recently I had a 73-year-old male, had lower back pain since 2017, and he's also had bilateral knee replacements since 2019. He has chronic pain. Of course he has chronic pain. His age and these surgeries that have happened, of course, there's no more digging we have to do. We should stop there. But when I asked the same question, when did your pain start? What was going on around that time? He mentioned both his parents had passed away and he was traveling back and forth to his home country. And he was dealing with stress between his family and lawyers and how the will was being enacted and the funeral proceedings. And it actually led to him disconnecting with his whole family at that time too. So even with these really basic at first cases, make sure that we're not missing those other pieces of the puzzle. These questions are important. So how does trauma connect to chronic pain? What's the actual physiological pieces there? Well, our nervous system, as we've learned, as I talked about 3 minutes ago, it's used to tell us about danger and to protect us. But what our brain does, it does a pretty bad job differentiating between physical danger and emotional danger. So just like our stress response, we can get the fight, flight, or freeze response from both a bear or a bank account. Our pain can be influenced by both physical and emotional things as well. So again, looking at the nervous system, our focus for chronic pain management is telling the nervous system it's safe, and we want to promote safety messages for them. So bringing this, if the client wants to go right to the source and get involved in trauma counseling, great. But really looking at that biopsychosocial model, we can influence their body and their social environment to influence that danger signal coming from their mind as well. So this is something even as straightforward as physio, we usually think of as strengthening muscles and bones, but looking through the lens of the nervous system, even this movement of me moving my arm here, it's sending impulses through my nervous system. And even psychologically, it's telling me I'm safe here. This movement isn't causing me pain and I'm able to take up space. So next slide. So with this, hopefully we went from sort of a bad news looking at the life experiences and looking at those things, how they influence pain. But what we want to do is use language that moves forward and ultimately inject hope. I say inject hope because again, our language and the words that we're using, I think it is a treatment and we're finding that that's the case as well. So I'll give an example. If we have two clients, both with osteoarthritis in their knee, depending on how we talk with them, it's going to set up their success for their chronic pain management. So with the first client, we tell them, oh, your knee has osteoarthritis. What that means is you have bone on bone grinding. That simply happens as we age. There's really nothing we can do to cure it. Meanwhile, the second patient, we say, your knee has osteoarthritis. That just means there's not enough fluid in between the joints, but we can increase fluid into that joint in many ways. So exercise is a really great way to sort of grease the gears and get more fluid into that joint. So I want you to remember the phrase, motion is lotion. There isn't an instant cure for osteoarthritis, but there's a lot of ways we can manage your pain. So I want to explore those together with you. So even just hearing those, I feel like the second one, it's not a trick question. The second one is obviously now set up on a path where they're more hopeful, optimistic, and they feel like there's some things that they can actually try. So bringing this back to the nervous system, this is where we can work with pain patients and say, the nervous system, and the brain, it's the most adaptable organ. When we learn about neuroplasticity, we learn that our brain is always changing. It doesn't matter what age you are. You can be 73 with lower back pain and bilateral knee replacements. Neuroplasticity, we can still find some wires that we can change here. And even though you've experienced trauma or different things in your life that have influenced that pain sensitivity, we can hopefully move forward, building resilience, trust, and ultimately safety. Next slide. So to end, pain management, it has many paths, but first off, we got to look at knowledge. I genuinely believe everyone is doing the best they can with the tools they have. So let's start giving patients better tools, starting with knowledge. Thank you so much. I believe we'll do a Q&A. Yeah, sorry.
Thank you, Drake. That was just awesome. Yeah, we have a couple minutes maybe for a couple questions if there's anybody who has a question or comment from our community out there. So please feel free, raise your hand.
I'll plug one thing while people are maybe getting brave enough to ask a question. With pain education, there's some really great leaders out there, David Butler, Laura Mosley, and I believe that was Adrian Lowe on there. But if you need a list or further resources for chronic pain education, I'll gladly send those out. So feel free to send me an email if you're wanting some more info as well.
We'll just let folks out there know that we also will be collecting all these kind of resources, and they will be available both on our kind of internal file system, but for the CMN members, but we can send these out as follow-up as well. Kathy, go ahead.
Hey, Drake. I'm curious about the clients that still are more focused on that biologic model and how you approach it through the nervous system. Do you get good buy-in, or does it sometimes take time? And then what strategies you use in order to clarify that? Because I often in my career have found that people want to know the cause, and despite my maybe limited ability to explain what I'm trying to do, I'm not quite as eloquent as you are, have had difficulty, and they get increasingly frustrated. So I'm curious how you approach that.
Yeah, great question. It's something that is really tough to get people to a place of understanding of, especially when they've had pain for again 5, 10, 20 years. Really, we use a lot of stories and metaphors and bringing forth studies, just so it's not just me saying these things. I'll show them kind of a great one that we use is looking at spine image findings versus incidence of back pain, and actually pulling up that study and looking at the graph right then and there. Admittedly, we do a lot of our program over group, and we're starting to do a lot more of that one-to-one piece now that we're having a little more in-person interactions as well. And it's very easy in the group setting to kind of run through a script, and in that one-to-one piece, it's really listening to the person and going, okay, what is the roadblock that they're having, and really hearing them before we start trying to provide that knowledge. Almost force feed it in that way. So really listening to what their barrier is and trying to provide an answer with that. But it's hard work. And again, as I kind of said earlier, it's something that if we say the wrong thing, or it's just kind of being open and humble with those things as well. I always set the stage that your pain is always real. And if there's a part that's really confusing for you, then it's more that I didn't explain it very well. So give me blunt honesty. If you think I suck, then let me know, because I'm here to help you out, and I want to figure out what those barriers are. So yeah, I know that's a vague answer, but it's a very, I guess, an intimate conversation for sure.
Yeah, great. Thank you.
Thanks, Drake. That's really, really useful information. I think super important to kind of manage these difficult and complex cases, and dealing with just talking to patients is sometimes just really, we have to have some humility in it too, and make sure that we can walk ourselves back from some things that we might say that we didn't mean to. So now I will move on, I guess, and we are really excited for this part of our ECHO program as well today. And I just wanted to just give everyone a chance to say hello to our hub team. And just if you wouldn't mind each one of our hub team members maybe to just unmute themselves and introduce themselves and tell us where you are and what your role is. And then I will get to introducing our first case presenter today.